was published in JAMA. This looked at 21 patients in Washington State. And as many of you certainly know, the Pacific Northwest, where Washington State is found, is home to Bigfoot. And I will give extra points at the end to anybody in the chat or who in the question session who identifies what movie this is from. So this was a very small case series, 21 patients that were admitted to the intensive care unit with COVID pneumonia. In terms of their outcomes, I show here this slide showing comorbidities. So CKD and CHF were the most common comorbidities with just over 40%. Diabetes and COPD were about a third of patients, and then asthma was present in 9%. This is not overly surprising that patients who come to the ICU generally have a higher burden of comorbid diseases. In terms of their admission symptoms, what I thought was interesting here was fever was only present in 50% of patients. This is, I think, relevant in terms of our screening protocols and thoughts about clinical likelihood of a patient having COVID, that only half the patients in this study had fever. More, about 75% had dyspnea, and again, less than 50% of patients had a cough. This is something that we already know from other data sets, that the median white blood cell count was 9,000, so not really much in the way of a leukocytosis, and patients were relatively lymphopenic with an absolute lymphocyte count there of 0.9 or 0.8 rather. In terms of their outcomes, so this is the clinical outcomes on the left and the percentages and numbers of patients, again, out of an N of 21 on the right. So severe acute respiratory distress syndrome was present in 12 patients, or 57%, and this would be a PF ratio less than 100. The admission PF was 169, which is not terrible, and the nadir in this study was 109. 4 patients received non-invasive ventilation. 1 patient was on high-flow nasal cannula oxygen, which I anticipate is lower than our experience in London. 15 out of the 21 patients, or 71%, received invasive mechanical ventilation. 50% were proned. And then you can see that the acute kidney injury, which was defined by KDIGO guidelines, was 19. And a new cardiomyopathy, or new evidence of left ventricular dysfunction, was present in 33%, which was diagnosed with a combination of BNP, troponin, and echo. In terms of the outcomes, they had, out of the 21 patients, 11 died, 2 were discharged alive from the ICU, and 8 remained in the intensive care unit. The second case series was published in Seattle. 24 patients, and for anybody who's not familiar with Seattle, they'll remember it from Dr. Evil's headquarters in Austin Powers, which was found in the Seattle Space Needle. And Seattle was one of the original epicenters in the United States before it was taken over by New York City. This was published shortly afterwards. In terms of comorbidities, again, some of the same ones, but diabetes was more prevalent in this study at 58%. CKD, asthma, and obstructive sleep apnea were slightly less common, and they did not report on congestive heart failure or other cardiac risk factors. In terms of their clinical presentations, similar. So here, cough and dyspnea were present in over 80% of patients. Less than half had sputum. 50% again had a fever, and the majority were tachypnic. In terms of their therapies and clinical outcomes, again, a total of 24 patients. 10 patients were on high-flow nasal cannula oxygen, which I anticipate is closer to our numbers. They did not use CPAP or NIV in this patient population. 18 patients were treated with invasive mechanical ventilation, and they proned 5 of those. 7 had neuromuscular blockade. In terms of inhaled pulmonary vasodilators, they used nitric oxide predominantly, but also Flolan or epoprostenol, and that was present in 28% of patients. In this study, they did not use ECMO. I just wanted to follow up on one point I made 2 weeks ago in our presentation, which at the time, as a group in London, we were advising or not recommending and certainly offering ECMO in very extenuating circumstances. But given the fact that our capacity and census numbers have been fairly low, we have, subsequent to that, the day or 2 after I gave that presentation, started to offer ECMO on a case-by-case basis. So that's sort of a correction to what I said 2 weeks ago. Anyways, back to this, 17 patients, or most, were treated with vasopressors, and in the 9 patients in whom an echocardiogram was completed, none showed no new left ventricular systolic dysfunction. In terms of their outcomes, I want to draw your attention to the first box, which is the median length of stay. So in ICU survivors, the median length of stay was 14 days. And this seems fairly accurate to our experience, and maybe even on the lower side, as we have several patients who've now been here for 3 weeks ventilated. In terms of their median duration of mechanical ventilation, overall is 10 days, which I suspect is lower than ours. They extubated six patients, 12 died in the hospital out of 24, and 1 were discharged from the hospital. Or they can jump in if I can't be heard. The next case series was a little over 2 weeks ago, and looked at 1,591 patients who were infected with SARS-CoV-2 admitted to the Lombardy region. Maurizio Ciccone is the second last author here, and he is the president-elect of the European Society of Intensive Care Medicine. So he did a talk where he talks about their early experience with COVID in the Lombardy region. And this is a picture of La Scala, which is in Milan, and one of the areas affected, and one of the countless artistic venues that's been closed. It's one of the sort of world's premier opera houses. In terms of comorbidities, some people would argue that being male is not a comorbidity, but it's just interesting here that it was 81% of their patients, under 50%. And then cerebral vascular disease was 20%, and diabetes was significantly lower than the American cohort, which probably is not that surprising. In terms of the treatment that they had provided, again, 1,591 patients. The average fraction of inspired oxygen, or FiO2, was 70%, and this was patients in patients with invasive and non-invasive ventilation. They proned about a third of patients, variables or patients on the y-axis. And I show this really to emphasize that this not
Paul, your audio is cutting out a lot.
And hours. Is that better, Lori?
Yeah, a little bit better for sure.
Okay. Is there a spot I should go back to, or just keep going? Was it bad for a while?
Just for, I think it was just the last set of slides, but that's okay.
Sure. I'll just recap quickly. I guess this, what I was talking about was this group in the Lombardy region of Italy, which Milan is sort of the center of. They found, again, that the majority of patients had, or many patients had hypertension, and a smaller preponderance of patients had cerebral vascular disease or diabetes. And the majority of their patients, 88%, were treated with invasive ventilation with high FiO2, fairly infrequent proning, and very infrequent ECMO. I wanted to put on this slide that a minority of patients were elderly, so a minority of patients were over 82, and the majority fell between 50 and 74. The PF ratio, which in this graph on the bottom left is right skewed, and so the majority of patients fell between 75 and 175, which would be consistent with severe or moderate ARDS. And the FiO2s were kind of all over the place. In terms of their outcome data, out of the 1,581 that they had data on, 405 had died in the ICU, with only 256 discharged. And as of the time of publication, the majority, or 920, were still in the ICU. So they quote a mortality of 26%, but out of all the patients who were discharged or dead, it was 62%. So this is one of the most interesting papers, I think, that actually came out yesterday in JAMA. And this is a similar structured case series with a lot more granular data that I won't cover, but looking at patients hospitalized with COVID-19 in the New York City area. And it was in 5,700 patients, so the largest cohort to date. In terms of their clinical presentation, they noticed that hypertension was fairly common at 56%. Obesity and diabetes were higher than in the Italian cohort, again, not surprisingly. A few things I found very interesting were fever was present in 31% of patients, so very significantly lower than the other cohorts. Tachypnea was present in 17%, and only 28% of patients who came in initially to the emergency department required oxygen. So there are a lot of patients that I think would not fit our typical classification or cognitive arrangement for what we think a patient with a viral pneumonia would look like. Another interesting fact was that the first COVID test was positive. So the first screening nasopharyngeal swab was positive in 98% of their cases who were eventually positive. And I'm not entirely sure how this would influence or how we could operationalize this piece of data, but I do know anecdotally that we are testing patients regularly and more than once if they have a first negative test. So I think it may not change our practice, but it's at least we're thinking about that majority of patients, at least in this cohort, tested positive initially. But what was really sort of stark about this is this table, which I've summarized some of their outcomes. So they treated 12% of their population with invasive mechanical ventilation, which is probably higher than what we'd initially predicted of about 5%. In terms of their mortality, overall the mortality was 21%. And these were all hospitalized patients, not just in the intensive care unit. But that's fairly high. The mortality of patients who did not receive invasive mechanical ventilation was 12%. What was really stark here was this is counting the patients who were either dead or discharged from the hospital. So a lot of patients were still in the ICU or in the hospital, but their mortality of patients who received invasive mechanical ventilation was 88%. And if you subdivide that by groups, in the 18 to 64-year-old population, it was 76%. And in patients over 65, it was 97%. And maybe somebody will be able to explain, I think in the comments or in the question session afterward, but I found this to be fairly astonishing. And I'll get to sort of why I think this is so impressive. The large caveat here is that a lot of patients were still in the hospital. And so we can assume that some of these patients who had prolonged mechanical ventilation were going to recover, just may take longer. So this is a table showing some of the amalgamated data from the 4 studies I talked about, and also another study that I didn't talk about from Wuhan, a case series looking at all hospitalized patients. And you can see, I guess in the second column is what I'm most interested in, the mortality. So from Washington State, again, this is the percentage of patients who died who were either discharged or dead after receiving invasive mechanical ventilation. And at the low end there is 62 in Italy, acknowledging that 900 of those 1,500 patients were still in the ICU, and going up to 97% in Wuhan and 88% in New York, which I just talked about. So these are fairly non-reassuring data. I think most of us would argue. But the first question, I guess, to put this into context is how does this compare to what we would normally expect to see with ARDS or severe hypoxic lung injury? So the first source I'd like to talk about, or the best source, would be this study from JAMA in 2016. This was called the LungSafe study. And what they did was looked at 459 ICUs in 50 countries. And they looked at, it was an international prospective cohort study of all patients receiving invasive or non-invasive ventilation over a period of 4 weeks. So they had 29,000 patients in total, 3,022 of which had criteria for ARDS. And what they showed was that the severity gradation was borne out in terms of mortality. So here is a graph showing the days of hospitalization on the x-axis and probability of hospital survival on the y, and mild ARDS, which is a PF ratio less than 300 but more than 200. Moderate is 200 to 100, and then severe is less than 100. you can see that these lines diverged. And you can get the survival data from this, but they also report it in a simpler form, which is the mortality at 28 days at least was 35% for mild ARDS, 40% for moderate, and 46% for severe. So RPF ratios that we saw in those case studies were between 75 and 175. And so we would expect them to be in the moderate to severe range. So it certainly seems like this is more problematic than just simply severe ARDS. The next question, though, is if those numbers are inflated, so if the survival data is going to be better, what does it look like in terms of those patients who survive? So we have multiple patients who've had 3 weeks of invasive ventilation, sedation, neuromuscular blockers. And I think that obviously there are no data that I could find about COVID survivorship, but we can extrapolate from some of the ARDS literature. The first one is one of the gold standards. So Margaret Herridge from Toronto and the Canadian Critical Care Trials Group published 1-year outcomes in ARDS survivors in New England in 2003. And they found, again, a series of things, but most prevalent, their primary finding was in terms of function. So this is a graph showing the change in weight of patients beginning at discharge, where they were 18% lower in weight than their admission, and that this never recovered. Even by 12 months, patients were not back to their pre-morbid weight. This is relevant because the majority of patients attributed their most pressing symptom, which was fatigue, to an inability to have strength and to weakness. They also looked at pulmonary function afterwards, and there is a bit more data in this chart than I would have ideally liked. However, I'll draw your attention to the categories, which were FVC, FEV1, total lung capacity, and then at the bottom, DLCO. And if you look to the far right of this table, it shows the data at 12 months. So this was 109 patients for context that they followed up after ARDS. So out of 80 patients, the forced vital capacity was 85%, and similar for the FEV1, which would be consistent with a restrictive pattern. Total lung capacity was actually normal, with the confidence interval crossing 100% predicted. And the DLCO was the most depressed value at 72%. So it was hypothesized that this and the potentially sarcopenia were the attributed by this acute illness would be Dr. Herridge's study from 2011. So they followed this cohort of 109 patients out for 5 years and reported on some similar pieces of data. What you can see here is the proportion surviving. So they lost about 6 to 8 patients per year in terms of survival. So the proportion surviving on the top slowly decreased down to about 80% by the end of the study. The middle graph, I think, is the most important, which is the distance walked during the 6-minute walk test. And you can see that the values approached 76% predicted by the end of their 5-year follow-up. So they did have functional limitation despite having normal total lung capacity and a mild restrictive defect. And then in terms of their psychosocial and neurocognitive outcomes, that's shown on the bottom. So the SF-36 is a comprehensive quality of life metric. The PCS is the physical component score. And the highest this got after 5 years was 1 standard deviation below the normal, with the mental component being in the normal range. Patients also had a plethora of PTSD, depression, anxiety, and other issues after this study. And the majority of patients, though, who were working prior to admission went back to work, but it was a fairly small cohort. So that's all I wanted to talk about for ARDS. I guess I would summarize that by saying the outcomes in COVID seem quite poor and significantly worse, I would argue, than even severe ARDS. And furthermore, in those patients who do survive, the majority of them have a long road to recovery and likely incomplete recovery in front of them. So now I'll get on to talking about CPR specifically in COVID. I think with that in mind, that the best data set we have so far is estimating 88% mortality in patients who have invasive life support. So what about the other end of the critical care spectrum? This study was just published in Resuscitation, and it looked at in-hospital cardiac arrest in patients with COVID-19 pneumonia at a Wuhan teaching hospital. So this is the Union Hospital in Wuhan. It is a tertiary teaching center, and it follows ILCOR and American Heart Association guidelines with respect to resuscitation. So this looked at 136 patients. In terms of the breakdown of demographics, 69% were male and 81% were over 60 years of age. So it was a slightly older population, but still 20% of patients under 60. In terms of the etiology of arrest, before I get to that, I would say that they had, relevant for our information, 83% of patients were ward-based patients. And so the rest were in the ICU, and the majority of them, 93%, had monitoring on the ward, which I would argue is probably higher than our ward-based population. All providers of CPR were from a rapid response team, which did intubation and CPR. They were on call 24/7, and all clinical and non-clinical staff had clothing, N95, and visor given to them at the beginning of the shift, as well as nurses were in each room at all times or switched off. So just to give you some context to their outcomes. So in terms of their etiology, 88% were felt to be respiratory, 7% were felt to be primary cardiac, and 5% were other. In terms of their presenting rhythm, asystole, for any of those non-electrocardiographers out there, was 90% of their presenting rhythm, and VT, pulseless VT or ventricular fibrillation, was 6%. So what did they find here? So again, outcomes on the left here, and then the percentages on the right. 13% of patients out of 136 achieved return of spontaneous circulation. At 30 days, 3% of patients were alive, and 22% of those patients who got ROSC were alive. When you subdivide it by rhythm in terms of the return of spontaneous circulation, in shockable rhythms, not surprisingly, the ROSC was higher, so 75% of patients. And in the asystole or PEA groups, asystole, it was 9% of patients. And what I think is most striking about this study, which I think should inform our understanding, is that favorable neurologic outcome was achieved in one patient, or 0.7%. So hopefully I'm slowly building an idea in everybody's mind that we're dealing with this very severely ill patient population that when they have a cardiac arrest in this fairly small study have exceedingly low likelihood of a positive outcome. But similarly, I think it's important to put this into context. So what is our experience outside of COVID, and how bad is this 0.7%? Because it sounds bad on first glance. So the majority of the data on cardiac arrest, and so if we can generate a comparison, comes from out-of-hospital cardiac arrest data. So I'll talk about that first. This is the most recent applicable trial that was the Paramedic 2 trial, and it looked at epinephrine versus placebo for out-of-hospital cardiac arrest. So this was all etiologies, and it was published, as you can see here, in New England. They had 8,014 patients, and 20% of those patients had a shockable rhythm. So what they looked at, their primary outcome was survival at 30 days with good neurologic function. And I'll explain this chart in 1 second, but survival at 30 days with good neurologic function on this scale was 1.9 to 2.2%, and it was not statistically significantly different between the two groups. This is a modified Rankin scale showing the differences between placebo and epinephrine. High numbers on this scale are worse and low numbers are better. So 6 is dead, and then 3, 4, and 5 are varying levels of dependency, with 1 and 2 being moderately disabled. And I guess what I would draw your attention to here is the majority of patients die, and those who survive, the majority of those have severe dependence issues where they are either unable to go home or require significant amounts of help with their basic activities of daily living. The other trial that I think informs us from the out-of-hospital cardiac arrest world comes from Toronto as well. So Damon Scales and Laurie Morrison, who are authors from UHN and Sunnybrook respectively, published this, which was a Toronto registry-based data looking at 9,882 non-traumatic arrests within the Toronto Regional Rescue Net cardiac arrest database. So it's essentially their EMS service keeps a database of all cardiac arrests, and they looked at the factors associated with out-of-hospital cardiac arrest. The most relevant table from this study was this one showing the mortality of patients by initial rhythm. So you can see here that at 30 days in the bottom patients who initially had PEA had a mortality of 96%. If they had a shockable rhythm, it was 78%. And if it was asystole, it was 99% mortality at 30 days. So one could argue that this is not as applicable because it is out of hospital cardiac arrest data, and we would need to know, compare apples to apples and know the in-hospital. So what do we have from that? Well, this was a review completed, as you can see, in last March, published in JAMA. It looked at two databases. So the American Heart Association Get With The Guidelines database that was published around the 2015 ACLS update, as well as the UK National Cardiac Arrest Audit from the Resuscitation Council. And they looked at cardiac arrest outcomes from the year 2000 to the year 2017. What they were looking at primarily was just the survival in general. So you can see here that over time, it gradually approached 20% where it was in 2017. But the other salient features from this paper were that survival at 30 days was 20% for in-hospital cardiac arrest, as I showed. 85% of those patients had a favorable neurologic outcome. And then in terms of the elderly, which they defined as over 65, 59% were alive at 1 year, while 66% were readmitted to hospital. So certainly even surviving the hospital discharge was not necessarily boding well for their near future. And then the last study I want to talk about from in-hospital cardiac arrest was published a number of years ago. And the main focus was to compare children and adults in terms of their in-hospital cardiac arrest rhythm and look at outcome. But I think it's relevant for a few reasons. This looked at 36,000 adult cardiac arrests. And what it showed was in the chart here. So return of spontaneous circulation in PEA or asystole in in-hospital cardiac arrest was 48%. This might be higher because a lot of these patients were in the intensive care unit and many of them were monitored when you look at the large databases. In terms of survival to hospital discharge at all, the PEA group was 11%, with VTVF being 36%. Out of that 11%, 71% had a good neurologic outcome, and you can see 75 in the shockable group. And PEA or asystole with a poor neurologic function had 17%. The reason I was focusing more on PEA and asystole is because of that CPR trial, and again, anecdotal evidence that the majority of patients who have COVID-19 pneumonia that's severe enough to have a cardiac arrest, we would expect to be on the basis of respiratory function, and then that would be PEA or asystole for the most part. So again, generally CPR data is not great, but what are we doing for CPR and protected or code blues at London Health Sciences Centre? And these are pictures of LHSC not in late April when it was snowing and hailing. So there's a document that is still, I think, in final draft form before the resuscitation committee, but I did speak with the chair of that committee on Sunday, so the data here, as far as I know, are still up to date. So first thing is that all code blues within London Health Science Centre are protected. And this means that they will be considered a possible exposure to COVID, irrespective of their swab positivity, swab pending, or clinical suspicion. So if there's a cardiac arrest in London Health Science Centre, it will be considered protected. So what does that mean? We'll get through some of the facts. In terms of personnel, most of it's the same. So we have a senior medicine resident, we have a CCU resident, we have the either CCTC or MSICU junior, nurses, RTs, and then as of this week, we have an intubation team, which is composed of an airway expert, so an anesthesiologist or emergency physician, an AA, an RT, or an RN. In terms of the differences in procedure, we have no bag mask ventilation unless absolutely necessary. And it's somewhat unclear what this would mean because in pulseless patients with no airway, they would have no ventilation. But generally, and in all cases, we're avoiding bag ventilation. CPR is supposed to be held during intubation because this is a time of maximum aerosol generation. We're recommending video laryngoscopy over direct laryngoscopy to decrease the distance between the provider's face and the patient. All patients should be paralyzed, but in most cardiac arrest situations, they will not have any tone, so won't need to be paralyzed. In terms of the video, what's relevant is there's one video laryngoscope per ICU, and this would need to be brought by the staff, either the residents or the RTs or nurse, to the code blue. And it would also have to be available. And then what does protected mean? This means that we're enhanced droplet contact precautions. So we would consider CPR an aerosol generating medical procedure. Providers would need N95, face shield, goggles, a bouffant, and a level 4 chemo gown with nitrile gloves. So the donning for this will certainly be much more involved than for a normal code blue. And the other two pieces of information would be, they used to be stocked in adequate amounts on the arrest carts before, but they were stolen. So now they have been locked within the units, and each unit is encouraged to keep an adequate supply. However, this is something that may be dynamic, and ICU teams at least are being encouraged to make pre-packaged bags and bring those with them to cardiac arrests, which would also require them to be in the ICU at the time of arrest to grab the bag or have to go back and get it. So I want to sort of paint a picture for you here. And I think the most apt analogy is Donald Trump's wall. So if we have a best case scenario, we're looking at an 8% approximately survival with good neurologic function in patients within hospital cardiac arrest. And this is with likely austere conditions, mostly monitored patients, and following strictly the American Heart Association guidelines. When you add on the fact that severe COVID pneumonia carries with it, I'd say conservatively, a mortality of 65%, the wall gets 10 feet taller, as we all know Donald Trump said. If you add on to this the fact that in the best scenario, so a nurse in the room in full PPE, the survival with good neurologic function is 0.07%, wall gets larger. Many of our patients will be unmonitored, and the doors are closed to their rooms, especially on the ward, so it's very difficult to monitor these patients. The time it takes to don PPE, which I think takes into account the fact that if units don't have PPE and providers show up without it, they have to go back and find it. The PPE may not fit because it's generic in size. And in our anecdotal experience, the fastest that someone's going to get on the full AGMP PPE would be about 5 minutes. So this is an increase in the pulseless time of these patients. We add to that the fact that there's going to be no bag mask ventilation, and also the fact that we're going to be holding CPR during intubation decreases the time of effective CPR. And add to this the fact that depending on the intubation teams, if there are 2 arrests at once, for example, some residency programs have directed their learners not to perform intubation, especially during CPR. So the residents who show up might be unable or unwilling to participate in airway management. There might not be a video laryngoscope. And we're expecting these patients to be an asystole from a respiratory etiology with prolonged time to CPR. So I think I've painted a decent enough picture, which raises the question of, should we even be offering CPR in this patient population? I think that I'll try and address sort of my thoughts around this, but I think it's worthwhile everybody thinking about whether there is still a role for CPR given the really profoundly disappointing outcomes data from this type of patient population. In terms of what the significance of this is for the ICU, I guess I can comment, and I'll get through to some of the CPSO stuff in a minute, but we were already doing this. So in patients who present to the ICU with an 80 or 90% chance of mortality, elderly comorbid patients on multiple forms of life support in multi-organ failure, we would routinely say that if they have a cardiac arrest, there's really nothing else we could do. But I'm wondering if there's a utility or a thought to extend this outside of that context. What does the CPSO say about this? There was a landmark case in the fall where physicians from Toronto placed a do not resuscitate order in a patient's chart. They notified the daughter by phone message, but didn't actually speak to her. And subsequently, the patient had a cardiac arrest, and she sued because CPR was not performed. And what they found was in favor of the physicians that although they did not communicate as effectively as they ought to have with the substitute decision maker, they are not compelled to provide CPR. So they put out a document called Potentially Life-Saving and Life-Sustaining Treatments, which I would encourage everyone to read, and does have a lot of very useful, important information beyond what I'm going to talk about. But the sort of meat and potatoes for this talk is the following. So point 15, physicians are not allowed to make a unilateral no CPR order. This would be like a medical no code, DNR, without the patient's consent or assent. So prior to writing this in a patient's chart, physicians must inform the patient or SDM If the patient or SDM provides consent, agrees, or provides assent, then this can be written in the chart and the health system can be notified. If they disagree, then the next step has to be a conflict resolution process, which we have a specific one at London Health Science Center for, and they cannot write this order until the conflict resolution is fixed. So in the interim, if the patient has a cardiac arrest, the last line of this is really the most interesting in my mind, which is that physicians must provide all resuscitative efforts required by the standard of care, which may include CPR. So how I would take this is that if you have a patient with multi-organ failure who has an asystolic arrest from respiratory failure and conflict resolution is ongoing, or it's not, and you come and assess the patient, that if they are full code, you should consider whether there's a rapidly reversible problem. And if it is in fact just the progression of their underlying disease, you do not have to provide CPR. It says here specifically that it may include CPR. So this is, I think, the far end of the spectrum. And honestly, this is what we'll mostly be dealing with in the intensive care unit. I would encourage residents listening to this to certainly not do this hastily. I think that this is something that would be coming from the consultant level or certainly in discussion if you're going to be going through a conflict resolution process and challenging this from a regulatory point of view. But I do think that there is a role for residents and having conversations, because outside of the CPR implications, as I talked about, invasive ventilation and life support is extremely poor in terms of outcomes here. So I do want to pause for 1 minute to just have the, again, mandatory meme slide. This is mostly for Dr. Devlin if she's listening. The top left corner, I actually saw more about this today, that the only thing we need right now is more ventilators, despite the fact that you do also need people to run the ventilators and medications. The bottom left, I still haven't actually seen Tiger King, which I apologize for. I've been watching The Last Dance, and I understand Carol Baskin is not good. We definitely need Chuck Norris. I think everyone can agree on that. That's not really political. And then on the far right, we see Batman taking Prime Minister Trudeau's words very seriously to avoid moist speak. All right, so I'll get back to it. What can we do as residents and as a recently finished resident? How can we approach the issues up to and including CPR? So I certainly can associate with this conversation where you start talking to a patient and we have these very convoluted conversations about, you know, one defibrillation, one CPR push, dialysis. And you know, if you look at this from the outside, if you didn't know anything about why this is happening, you'd be kind of confused why we're having these intricate discussions with a patient about vasopressors, which they realistically have no chance of understanding unless they're in healthcare. And the reason behind this, I think, is this picture at the bottom, which is everybody's favorite resuscitation care order set. And the reason I think we have these conversations is because we have to choose one of these boxes. We're reminded by a friendly prompt and power chart that patients, we must know if they want to use vasoactive drugs or cardioversion or defibrillation. So the most straightforward way of figuring this out is just ask the patient. And this is one of those conversations at the top where we have a menu type situation. But if anybody's been listening to Joe Biden's speeches from his cave, this is what the conversations often sound like. And again, I can say this from experience. I'm not trying to exclusively poke fun at residents, because this is what I would have done. And this is what I did when I was a medical student and resident. It's kind of meandering, starts off, well, CPR and then ribs. We're always breaking ribs. And then it's defibrillator, like you don't want electricity. And do you want BiPAP, the tight fitting mask? So it's usually kind of helter-skelter and all over the place. And I think the reason, again, is to fit this into those boxes and power chart. But the thing that's important, the important considerations here, first of all, we do need patients' consent or agreement or assent in order to withhold CPR. However, the same is not specifically true about, or hasn't been specifically stipulated by the CPSO in terms of other forms of life support. So all the other things on that sheet really do not need to be specifically consented to. So if you're not going to ask the patient, do they want vasopressors, how can you check that box off? Well, what I would encourage you is I'm going to sort of explain a model that we use in the ICU, and it's sort of similar to how you would offer a patient surgery or any other procedure. Before I get to that, I'll just talk about some of the problems with this type of DNR conversation, where you have an explanation of CPR, vasopressors, dialysis to a patient who doesn't really understand. They may say, I want everything done, and that's usually followed up with trying to explain why that's a bad idea. The problem with the way that the DNR is done currently, firstly, it's out of context usually. So these were previously outpatients seen in the emergency department who, for the most part, were well, or they felt that they were well. So this kind of comes as a surprise and doesn't really make a lot of sense to them. The most important feature here is that this is not patient-centered or outcome-centered at all. So patients do not care if they have vasopressors. Vasopressors, with few exceptions, do not induce undue amounts of suffering or harm. The patient can usually not even tell that they're on a vasopressor. So why would anybody care about that? And I think the same applies to things like BiPAP and cardioversion, where a patient doesn't know if they want, certainly nobody wants this, but they don't know if it's going to be beneficial. What they're curious about is, can they go home? Is it going to make them feel better or worse? How will it impact their outcome? And is the suffering that they may entail in proportion to that outcome? And this is something that I also find coming in as the third or fourth person when we come to discuss the actual provision of intensive care therapies, is that the conversations have often, up to that point, been antagonistic, where, as I mentioned, you offer therapy, a patient says yes or no, and then if they don't say what you want, you usually try and explain to them why they're wrong, and this leads to an erosion of the therapeutic relationship and a breakdown in trust, so that when the ICU shows up, oftentimes families and patients are primed to dig their heels in and have a fight. So what's a different way of doing this? We talk a lot, I'm sure, in medical school and residency about goals of care discussions, and I'll just explain to you how I conceptualize it from an intensive care unit point of view. The first thing that you really want to elucidate when you're going through a goals of care conversation is their function. So fairly briefly, but having an understanding of their frailty, so their vulnerability to medical insults, have an understanding of their mobility, which relates to frailty, and their cognition. And this should really come out through the collateral or the history of presenting illness. It's important to elucidate a patient's values, and I'll explain why this should be part of the clinical interview in a second. But you really need to know things like this. What makes the patient's life meaningful? What kind of things would they need to be able to do in terms of the recovery? How would they tolerate, or how would they deal with being dependent for basic activities of daily living? How would they feel about living in an institutionalized setting, or in worst case, in a custodial life support setting? The reason that these two things are important is because you cannot really make a recommendation, or you cannot guide a patient towards a decision around something like vasopressors, which they have no context to understand, unless you know what they can do at baseline, what they need to be able to do to have a meaningful life, and then you can place that into the context of your knowledge of their medical situation. And specifically in COVID, you understand the high mortality with things like invasive ventilation and the very poor outcomes that we're suspecting with cardiac arrest. Then you can roll that back into a recommendation. So this is just an example, but something like, based on our conversation, based on what you're able to do now, and what I know you would want in order to have a meaningful life, I think that what we should do is we should give you good antibiotics, IV fluids, oxygen. If things don't get better with that, then I honestly don't think that other forms of invasive life support are going to be helpful. So I think at that point we have another chat and talk about things like medications to make you more comfortable. And anecdotally, I can tell you two things. This works much more often than I previously thought it would. So I think we go into a lot of these interactions expecting an adversarial relationship, but a lot of times if you base it on their goals and values, patients do respond and agree with your treatment recommendation. And the other thing is that I think I mentioned, when we have patients come to the intensive care unit, we often say that we will offer certain therapies or not offer certain therapies based on their underlying frailty and comorbidities, totally aside from COVID, and patients understand the vast majority of the time. The final point I'll make about these conversations is, if you are not planning on spending the time to get this accurate and have a thoughtful conversation, probably the best thing you can do is understand what they would absolutely not consider having, because that's important for the hospital's documentation, but try to avoid the antagonism and the arguments that can sometimes ensue, because it makes the job much more difficult later. I think that if you, in terms of phrasing, what we would encourage people to talk about is, as opposed to would you want this or would you want that, would you be willing to be considered for this? And so that they have it in their mind that if they get to the point where they would potentially benefit from a therapy like dialysis or invasive ventilation, would they be willing to have a conversation with the provider of that therapy, who is the ICU, the nephrologist, the cardiac surgeon, or whomever. So that's the end of my presentation. In terms of the summary, I think I probably painted the picture that outcomes for patients with critical illness in the context of COVID are very poor and significantly worse than ARDS, with some caveats that the final data may be different. CPR under the best conditions, best case scenario, has fairly poor outcomes, and that the likelihood of a good neurologic recovery in the context of a patient with severe acute respiratory syndrome from COVID-2 and a respiratory cardiac arrest with asystole, I would say, is exceedingly low to impossible in terms of a good neurologic recovery. I think it's important to note there is a framework that exists within the CPSO for withholding CPR, but that this should be used fairly judiciously and with full understanding of the ramifications of this conversation. But aside from CPR, I think that changing from what do patients want and going through the menu of options for the DNR status, but I would recommend we focus on a function assessment, look at their values, and then follow up with a recommendation whereby the physician can choose the DNR status that's most applicable. So with that, I hope